Okay.
All right. So thanks everyone for coming, because I know sometimes when people read the word hospice or they hear the word hospice, they go running in the opposite direction. So I appreciate you all coming to watch this presentation. I am working on my master's degree in nursing education, and I'll be done in just a few weeks. So I'm using this as a way to meet my practicum requirements. So there's a little evaluation tool floating around if you don't mind filling that out for me so that I can submit that as part of my project. So anyhow, today we're going to talk about hospice and palliative care, and I put the title here as It's About Living because that is the focus of hospice and palliative care. So I know a lot of people recognize hospice and they think that it's all about death and dying, when really you think about death, it's just a moment in time in that continuum of health. You know, there's a lot of time that you live before you actually die. So hospice and palliative care both focus on quality of life and maintaining that quality and identifying goals in that period of time before death. So I think I know everybody in here, just about, but if you don't know me, my name is Nicole Mandros, and I've been a nurse for almost 7 years, and I've worked at the hospital most of that time, and then in February I started as the executive director at Hospice of Sweetwater County. So I'm also presenting this in a way to share with you the love I have gained for hospice in the last few weeks. I think the hospice philosophy is absolutely amazing, and it's a really, really interesting specialty to go into. It's a very different type of healthcare. It's a complete 180 perspective than when you're working in the hospital in acute care. So it's very, very neat. So just to start out, we're going to talk about what is hospice and palliative care. What do those things mean? So palliative care, it's a holistic approach, and it focuses on quality of life and maintaining comfort. And so anyone can be eligible for palliative care. It's usually for people who have diagnoses of serious illness, chronic illness. But we focus on the quality of life. So we're going to help the patients to identify healthcare goals and to ways to meet those goals and what quality of life means to them. And so we help educate them on their disease process, help them understand their prognosis, help them understand what types of things they're going to experience, especially if their illness is going to be progressive or lifelong. So we need to educate them early on the fact that someday you're going to be at the point that you might need to consider hospice. At some point in your life, you're going to need to consider these types of medications or this type of treatment. So we're really focusing on education to help coordinate their care and to help make sure that they get the things that they need and they want. So anybody who wants to enhance their quality of life is eligible for palliative care. And hospice care has the same focus, so we want to focus on quality of life and maximizing comfort during the period of time that we have left. The difference between palliative care and hospice care is with hospice you have to have a terminal diagnosis. So if a person has a disease that would result in death within 6 months, if it runs its normal course, that would be the definition of terminal illness as far as hospice goes. So we have the same focus, like I mentioned. We talk about comfort and quality of life and enhancing those in the way that the patient feels is best for him or her. So we work with the families and the patients together. It's a nice cohesive process, and we make sure that we identify what end of life means to them, what their goals are, what types of treatments they want or don't want, and what we can do to help them with their quality of life. So terminal illness also has to be certified by 2 medical providers, and patients have the right to choose their own attending. So the attending physician would be one of the providers who certifies them as terminal, and then a hospice director, a medical director, would also help to certify them. Patients in hospice care, they also are choosing comfort and quality of life over curative treatments. So they're no longer eligible to receive invasive treatments that's going to help cure their disease or lengthen their life. Hospice care also strives to provide care within the home or a similar or a home-like environment. So you'll see patients in assisted living, in nursing homes, in their own homes, or in hospice houses. So I'm going to talk a lot about common misconceptions about hospice, especially things that we as healthcare providers even believe at times. So some of these are things that you may be under the impression that it's true when it's not. So one of the first misconception I'm going to talk about is hospice is only for people who are dying. So that's not true, because patients who have a terminal illness does not necessarily suggest imminent death, because patients can be on hospice for several years if they continue to meet the criteria. It's better if patients are admitted early on, because hospice is ideally designed to help provide services over the course of months and weeks and potentially years if they're going to live that long. But we want to admit patients early so they get the maximum benefit of our services, and that they can, we can prepare them and their family as much as possible for their final moments. Currently on our service, we have more than half of our patients are independent, and they're still able to take care of themselves. They can still go out and drive. You don't have to be homebound to be a hospice patient like you would if you're on home health. We have patients who travel to Wendover every month to go gambling, and we have patients who have gone to watch their child get married in another state. We've sent patients across the country to see a grandbaby be born. So you don't have to be homebound and dying to be a hospice patient. Let's see what else we've got on here. Oh, so many patients and their families wish they would have known about hospice earlier. So when we send out surveys and we ask patients, how are they satisfied with their care? What do they think about hospice? A lot of them say, we wish we would have known about you sooner. We wish you could have come in earlier, because we love the services that you've provided, and we would have liked to have had those for many more months. We could have avoided excessive pain or other treatments that were unnecessary. Another misconception is that patients who live beyond their 6-month window are no longer eligible for hospice. So nobody gets kicked off hospice if they live past 6 months. The physician has to recertify them. So during the first 6 months, the medical director has to certify them as terminal initially. They see them after 90 days and then after the second 90 days, and make sure that they're still meeting the criteria for hospice. After that 6 months, then they're reevaluated every 60 days. And so as long as they're still meeting the criteria for hospice, as long as their diagnosis is still considered terminal, would result in death after 6 months or within 6 months if it runs its normal course, they can continue hospice services. So right now at our hospice, we have a patient who's been on our service for over 2 years, and she continues to decline slowly, and she meets the criteria every time that she is reevaluated. So just because you don't die in 6 months doesn't mean you cannot continue the services. It's also important to note that patients can be discharged if they get better, if they have a recovery, or if they just don't want to be on hospice anymore. So once you commit to hospice, you're not on hospice for the rest of your life. You can revoke hospice services at any point in time if you choose to resume curative treatments. Another misconception is that patients are not allowed to go to the hospital and are not allowed to see their own personal provider if they're on hospice. And so that is also untrue. So patients have the right to choose their own attending, like I mentioned before, and so they can continue to see their primary care provider. If they still want to see a specialist, they can do that. It's just that Medicare hospice benefit doesn't pay for that. So they may have to put out some money out of pocket to see a specialty provider, but they are allowed to see any doctor that they wish to see. If a patient has an event that occurs, so say a patient is on hospice for COPD, and they fall in their home and they break their hip, they can come to the hospital because the hip fracture is unrelated to the terminal diagnosis of COPD, and they can come and they can receive invasive treatments. They could have hip surgery if they so chose. They could go to Utah and have surgery if they needed to. If they did leave the state, they would have to be discharged and readmitted upon return to the state. But they are allowed to have invasive treatments and curative treatments for a disease process or for an event that is not related to their terminal diagnosis. As I mentioned, they can revoke services at any time. So if for some reason the patient decides they no longer want hospice services and they want to come to the hospital, they're more than free to do that. And also, if there are times that their pain or their symptoms are not being able to be managed within the home or the home-like environment, they can be admitted to the hospital under general inpatient criteria, and they can be treated here. So they will be continuing the course of hospice care, it's just in a different environment of the hospital. So hospice patients can definitely come to the hospital if they so choose. There's also the option of respite, so say the patient is within their own home and the caregivers need to go on vacation or they just need a break, they can bring the patient to be admitted to the hospital or to long-term care facility for respite, which is up to 5 days. So they're still getting hospice care in the same care plan, it's just in the hospital environment or in a long-term care environment. Another misconception is that hospice care is expensive. Hospice is covered by Medicare and Medicaid and most private insurances. And then many hospice programs are nonprofit and they do receive donations and memorials and grants and things like that to help supplement care. There are some hospices that provide sliding scale fee services, so it really depends on what's available in your area and what kind of coverage that you have. And hospice programs are required by Medicare to provide certain medications related to the terminal illness, pain medication, anxiety-related medication, anything that's related to the terminal diagnosis, as well as medical equipment and supplies. So hospice does come to the home. They will bring oxygen concentrators. They pay for the oxygen if that is needed by the patient. They'll bring and pay for hospital beds. They bring attends, bathing wipes, shower caps, all the different things that you might need, gloves, different things that you might need to care for your loved one in the home. So hospice care is typically not expensive. There is usually very little out-of-pocket cost. Another misconception is that hospice is only for patients with cancer, and that's not true either. That tended, in the past when hospice first came about, the majority of the diagnoses were cancer-related. But as we've come through the course of time, we're now less than 50% of patients on hospice with cancer. So currently 60% approximately are non-cancer diagnoses, and I have them listed here. So we have dementia, heart disease, lung disease, stroke, renal failure, liver disease, ALS, and HIV and AIDS. So you can see that there are many diagnoses that qualify for hospice that are not related to cancer. And it sounds like Medicare is looking into some different criteria as far as advanced age, because there are patients who are, in their 90s, they're over 100, and they are clearly deteriorating, but they don't fit into any of the criteria that's currently available, so they can't be admitted to hospice service. So it sounds like Medicare is trying to come up with another category of criteria for advanced age. So I think that would expand services quite a bit. Another misconception is that patients must discontinue all medications and treatments to be eligible for hospice, and that is untrue. So there are certain treatments that they should discontinue if they would like to come onto hospice, and that's just based on the philosophy of hospice care. If you're choosing comfort and quality of life, you're not going to necessarily want to be getting surgeries and invasive procedures and stuff like that. So those types of procedures and treatments are not covered by the Medicare hospice benefits. So typically patients need to discontinue those types of services in order to be eligible for hospice. And also, if we take away all the patient's medications, then that can really adversely affect their quality of life. So if we have somebody with congestive heart failure and they've been taking Lasix and beta blockers for many years, and now they come on hospice and we take those away, they're not going to be very comfortable when they have tachycardia and they're extremely dementive. So we don't take away medications or treatments from the patients. It's a collaborative effort. The patients, their families, the physicians, the care team, they all get to make those decisions together, and the patients choose which types of medications and treatments they wish to continue and which ones they want to discontinue. And it's pretty common that the patients like to start weaning off of some of the medications. They'll stop taking vitamins and other supplements and things like that, anticoagulants, because they just don't want to take that many pills every day. At the point that the patient is no longer able to swallow, we do typically discontinue oral medications because it's a safety concern. So that would be the only time that we would stop a particular medication that maybe the patient would have wanted earlier in the course of care. Just some other common misconceptions to put on here. Electing hospice care means that all hope is lost, and that is not true as well. So we encourage patients and their families to have hope until the final moments, because if you don't have hope, you're not really living at all. It's just not a significant plan. So hope is not a plan. That's something we educate patients and their families on all of the time. that we definitely need to have hope, because things do happen. Sometimes patients get better, sometimes miracles do occur, sometimes patients' cancer goes in remission. So you can't give up all hope, but we just need to make sure we have a plan for how things could go. Another misconception is hospice is only for the elderly. Typically the patients are of advanced age, over 65 is what it says, 84% are over 65 and 41% are over the age of 85. But there are pediatric hospices. There are, patients are accepted regardless of their age. It's all dependent upon their eligibility criteria. And then another misconception is that hospice care ends at the time of death. So all hospices are required by Medicare to provide bereavement services for up to 12 months after the patient dies. So hospice does not just end at the time of death. I put on here some implications for hospital employees, because what does this mean to all of you? So as healthcare providers, I think it's really important to familiarize yourself with the advance directive forms, because we want to start the conversation early. We want to know what patients' wishes are, because it's really difficult to admit patients to hospice when we're in crisis mode and the patient is imminently dying. So it's really great to start the process very early and to start talking with the patients about end-of-life wishes, making sure they have advance directives, making sure they have an advocate assigned, making sure that their wishes are documented and that everybody's aware of what those wishes are. It's also important to, encourage the patients to have these conversations with their providers and with their friends, with their family, just making sure that everybody is aware of what the patient might want in terms of their healthcare needs and their end-of-life needs. Also important is hospital employees to identify the patients that are declining, that are coming into the hospital repeatedly. It's pretty easy to identify those patients, but to take it one step further and start having the conversation with them about, what are your goals? What does quality of life mean for you? What does your treatment plan look like to you? What types of things are you wanting to do in your life? That way we can help them to make the plan so that we can help address those needs sooner rather than at the very last moment. And we tell everybody that it's never too early to refer a patient to hospice. So if you are concerned at all about the status of the patient, the way they're declining, what they have going on, you're not sure if they meet criteria or not, you can always call us and we're happy to evaluate the patient and see if they do meet criteria. And we're always open to explaining our services to any patient and their family at any point in time. So something to think about as a community member, as a patient yourself, as a family member, as a loved one. The same types of things apply. So you as your own self should make sure you have your advance directive documented. Make sure your healthcare wishes are known to your friends, your family, your loved one. Make sure that you know what your friends and family's wishes are as well, so that in case you do need to be their advocate or their proxy, then you can make those decisions to help support what they really want. Again, it's never too early to make plans for the future, because you never know when you could be presented with a serious illness, a life-limiting diagnosis. So here's some specific information about Hospice of Sweetwater County. So we are a nonprofit organization. We've been in existence for about 33 years, and we were started by 2 nurses in the community just on a little tiny grant, and we've grown to the point that we are now. Our current census is 17 patients, because we just admitted 2 over the weekend. So we do have a fairly high census. I think in previous years we were in like the 8 to 10 range, and we really exploded in this last year. So we have a lot of patients currently under our service. We do serve all patients within the county. So right now we have 2 patients in Farson. We have lots of patients in Green River. The bulk of the patients are in Rock Springs. We do have 1 patient that's up past Farson. So we do travel throughout the community, or throughout the county, to see patients if they need us. So don't be concerned about where your patient is living if you're thinking about referring to hospice, because we do travel all over the county. If there is a place that's really far away, maybe it's bordering another county that has a hospice, we can help contract with the other hospice to get those services provided to the patient. We do provide our services to all eligible members regardless of age, gender, ethnicity, and ability to pay. So we function a lot off of grant money and donations and county assistance. So patients under our service never receive a bill. Patients and their families are never billed for our services. So even if they don't have any pay source, we will absorb that cost. So that's something very important to share with patients and families, that in our particular community, you can receive these services without having to be concerned with finances. We do bill Medicare, Medicaid, and private insurances. So if those payers do pay, then we take that as payment, and then we supplement the rest with grants and memorials and donations. We do serve the patients in their homes, skilled nursing facilities, assisted living, so we do have patients in all sorts of different areas. If the patient is in the hospital, we can admit as either general inpatient if they are having severe symptoms that are requiring hospitalization for management, or we can admit them as like routine home care. So we treat the hospital as their home while we're trying to make them a plan to get them out of the hospital. And so we are supported by the county, but we are our own independent entity. As far as our services that we provide, we are available 24 hours a day, 7 days a week. So we have nurses who are on call to help coordinate care. And Dr. Ali is our medical director, and so he has been available as well 24 hours a day, 7 days a week. So if we need emergency orders on patients, then he can take care of that for us. So as mentioned before, Medicare does mandate that we provide medical equipment and supplies and medications, so we do that as part of our service. We will provide all the medications that are related to the terminal diagnosis. So if a patient wishes to continue a medication that's not related, then typically they pay for those medications out of pocket. Our hospice does hold grief support groups, and that's 2 nights per month. It's every other Thursday. I think it's the first and third Thursdays, and that's over at our office. Then Colby Williams is our support services coordinator, and so she takes care of all the bereavement, and she does do individual appointments as needed. We provide bereavement services not only to families of our patients, but to anyone in the community. So anyone who has suffered a loss, whether their loved one was a hospice patient or not, can use our bereavement services. We do have contract services such as physical therapy, respite care, so if our patients do need those types of things or wish to continue those, then we can help them get those services. We do provide educational resources to patients and families. We do have some things on our website. We do have a library in our office, so patients, families want to come in and check out books or watch videos, they can do that also. And then we do provide in-services to our contracted agencies to make sure that staff understand what our philosophy is and how to take care of the patients that might be in their organization. And then we also try and provide community education about advanced directives and our philosophy and the types of services that we provide. All of our care plans are individually based, so our interdisciplinary team and the patients, they all meet and they get to discuss what types of cares and treatments we want. And the visits are also individualized. So Medicare mandates that an RN lays eyes on a patient every 2 weeks. That is what is mandated, and that is what some hospices do around the country. But our hospice makes sure that we see our patients at least once a week. Most of our patients get twice weekly visits, and then some are on daily visits depending on their individualized needs. We do have CNA visits. Those are typically 2 to 3 times a week. We have a chaplain who will visit as frequently as needed, social workers. So our patients are seen much more frequently than some other hospice organizations. So our interdisciplinary team consists of Dr. John Ilea, and he, as you know, is a surgeon in the community, but he is board certified in hospice and palliative medicine, and he is extremely passionate about end-of-life care, palliative care, hospice. So he's an excellent resource. He, like I said, is very, very passionate about the cause, and he does an excellent job with the patients and their families. We have a director of patient and family services. Right now we have 4 full-time RN case managers. We have 1 leaving, so we're currently looking for a replacement. We have 2 on-call case managers, and we're about to pick up a 3rd. So we do have, our patient-to-nurse ratio is 1 to 5. So we do, because they are coordinating all of the care, and then they're actually seeing patients. They're calling in prescription medications. They're refilling, they actually go pick up the medications, drop them off. They coordinate delivery of medical equipment. So they are on a 1 to 5 patient ratio. We do have a hospice aide, we have a chaplain, a social worker, our support services coordinator, and then we do have a pool of volunteers. So we have volunteers who go into the patient's home to spend time with them. We have volunteers who do administrative type work in the office, so we do have a nice volunteer pool as well. So currently we have some stuff going on between hospice and the hospital, so a little bit of information about that. So we are planning on working together to meet mutually benefiting goals. And some of those goals are, hospice, we would like to have earlier hospice referrals because that really allows the patients and their families to get the maximum amount of services that we offer. And it helps them to prepare as best as they possibly can for those final moments. When patients are admitted to hospice, then it does help to reduce hospital readmissions, which we all know is a big concern because of the payment or lack of payment from Medicare. So the hospital's wanting to reduce readmissions, we're wanting to get earlier referrals, so working together we can make some of these goals happen. So the hospital right now is working on building a palliative care team, which I think is the quality of life team. Yeah. So we're working on, the hospital's working on that, and ideally we'll have nurse champions who can help address end-of-life needs with the patient. So we're gonna start talking with them earlier about advanced directives, making sure that they have plans for their healthcare wishes, what types of things they want and don't want. And so it's typically very education-based. A lot of like what Greer does, she's making sure that patients understand their diagnoses and make sure that they can manage their medications at home, follow up on their appointments and things like that. So it's really about coordinating all of their care. Hospice, as part of this team, is going to help to provide education because it is difficult to have those conversations with patients, especially for physicians sometimes. They don't want to be the one to say, I'm really sorry, there's not a whole lot else we can do for you. Let's explore hospice care, because they feel like they're giving up and that they're giving up on their patients. So, those conversations are difficult to have. So hospice, our nurses are trained to have difficult conversations with patients and families. So they are going to help educate the staff members and the physicians here at the hospital to help with this palliative care team. And then I put on here some resources. So if you wanted to know more about hospice and palliative care, there are some different websites you can go to. So the National Hospice and Palliative Care Organization has a website for healthcare professionals as well as for patients and families and just anyone in the public. So the website that's on here, caringinfo.org, is the one that's streamlined more for patients and their families. So if you wanted to learn more about what types of different hospices there are, about grief and loss, then you can look on that website. This week it's National Healthcare Decision Days, and so that's a national movement that is trying to get patients and their families, everyone in the country, to create advanced directives, to start identifying what their wishes are and get them documented, finding a proxy or an advocate to represent them if they are no longer able to make decisions. So it's a really great website that you can visit, nhdd.org. And they have a lot of tools that you can download, and you can give packets to patients and say, here's how to have this difficult conversation with your loved one or with your doctor, or take this home and here's a worksheet in here that can help you identify some of the goals that you have for your healthcare needs and where you want to be in this continuum. The Conversation Project is very similar. Those two entities work well together. And they also have information on advanced care planning. There are a lot of different resources that you can download. If you want to learn more about Hospice of Sweetwater County, we do have a website, so that's put on here too. And otherwise, I just have references for the presentation. So does anyone have any questions? Yes.
I know in the past, Nicole, when we would work with patients and families in hospice, they would say that it's required that the patient has access to 24-hour care in order to be signed up for hospice. Can you talk about that? And is that still part of the
I should have put that
philosophy?
in here. Yeah. So patients do not have to have 24-hour caregivers to be admitted to hospice. What we need is for the patients and their families to have a plan for what happens when the patient does need 24-hour care. So if the patient is currently, fairly independent, they do have the terminal diagnosis, but they can go home and live by themselves and take care of themselves, we will admit them. We just want to know that when the time comes that they're no longer able to take care of themselves, that they have a plan. Maybe a loved one is going to take FMLA and come and be their primary care provider. Maybe they're willing to go to a nursing home for hospice care. So They don't necessarily have to have 24-hour care at the point of admission unless that's what they're going to require at the point of admission. Any other questions?
Will you come to the hospital and consult if we have any questions?
Yes. So the hospice nurses will come and do consults, especially for pain management. So they are the experts on pain management. And if there are patients in the hospital that were having difficulty managing pain, they are more than happy to come up and do consults for that, as well as any patient that you guys have that is imminently dying in the hospital. They are willing to come and provide any sort of input that might be needed. Any other questions?
You will admit on the weekend, or?
Yes, so we do admissions on the weekend. We like to have referrals during the week just so that we are able to get medical records and everything that we need. A lot of the providers are not on call, so if somebody has a primary care provider that's just a clinic doctor, and they're not on call, it's difficult to get a hold of them on the weekend to verify that the patient is terminal. But if we could get all of that stuff coordinated, then we would be happy to do referrals and admissions on the weekend.
Is that the same for the ED? You admit from the ED? If you have that information available to you?
But if you don't have information, then they don't get admitted.
Right, because we do have to have 2 physicians that are certifying that the patient has a terminal illness. If the ER physician is willing to say, I think this patient has a terminal illness, and we can get records and fax them to Dr. Elia, and he can review the case and say, yes, I agree, then we would gladly admit on the weekend. It's just we have to have all that information lined out and have the 2 providers certifying that the patient is terminal. Any other questions? Yes?
So in the hospital setting, patients come in and are often in a crisis mode and might not be able to make these decisions as we're in the hospital. So do you see opportunities, I guess, with our clinic, or do you even see people referring from our clinic currently in the outpatient setting? Can our clinic refer?
Yes, so we do get referrals from the clinic. We have quite a few of them that the physicians will refer them to hospice, so we do admit from the clinic. Is that what you're asking? Yeah? Okay. And we get self-referrals as well, so patients whose family decide that they think they need to be admitted to hospice, they can refer to hospice. We also get outpatient providers, inpatient providers, and providers from other states even. So we've admitted from Utah, from University of Utah if necessary.
So with self-referrals, then you have to get a physician at some point, right?
Yes.
And you have to go.
Yes, so if the family member calls and says, I think my loved one is a good fit for hospice, we're interested in that, we have them tell us who their primary care provider is, we contact the provider, we get medical records, we talk to our medical director, and then we make the decision based on that information.
I was just going to say, so do you have an information sheet where, say, a family's not ready right then, but maybe they get home a few days later? So do you have maybe a referral form or an information form that case management or the nurses can give to the family?
So our referral form is just a template right now where we ask different questions and we collect the information, but I don't see why it couldn't be used by case management or by the families.
So you don't have any brochures?
Yeah,
We do have brochures, yes, that explain our services. We do have brochures.
That we have, do we have them?
Yes,
Okay.
yeah. I remember seeing some upstairs in the little
Okay.
cubby outside of case management. And I hope they have them in the clinic. Have you guys seen them over there?
Not family practice.
Oh,
so.
sure. Okay.
What
We'll
about-
make sure that everybody has brochures.
What about the circumstance where you may not have all the paperwork or everything that you need, and they come into the hospital, and the family's kind of, they've decided to go with hospice, but we know sometimes it ends up, you do all that, hospice can do to get them in, but there may be some other barriers or roadblocks where it's family or something. Does hospice still cover for certain, you did have the respite on there for 5 days, but are those just for existing, on people that are already on hospice service, or how about those that are just coming on to service
And you
with
don't
that
have.
admission?
So we're not allowed to admit to respite anymore. So the patient already has to have hospice services as an outpatient. So out of the hospital, they're set up, and then they come in for respite. So we used to be able to admit to respite for that 5-day window, and then they could go home or nursing home or wherever they were being placed. So now we have to admit them as routine home, and we treat the hospital as their home, and we try and still move them to another location within 5 days if it's possible. Or if they're imminent, they can die here.
And are you, are the nursing homes accepting that more readily, going into the nursing home as a hospice patient?
They are. Yeah, we have several patients at both nursing homes right now. So they do seem very willing to admit. I think the tricky part is the payment source. So if a patient just has Medicare, then they expect payment up front as a deposit. So that's very difficult for the families. But if the patient has Medicaid or private insurance, then sometimes they can go right in without any additional concerns. Yes?
You may have already mentioned this, but did you explain or talk about both three?
Oh, the rhythms? No. So I can talk a little about that also. So we are going to roll out some new brochures, and I think everybody's already seen them because I think they've been floating around in the community, but it's for a rhythms program. So we are going to start, it's just a way to have a conversation with the patients. It's a brochure, and it kind of helps to start the conversation for those who have end-stage heart disease or end-stage lung disease. So it's a nice way to say, hey, we noticed that you have this diagnosis. What are your goals? What are your plans? Do you want to have you been in the hospital a bunch of times in the last year? Do you want to keep taking all these medications? Do you want to keep continuing what you're doing? Or do you want to explore some other options? So we just got our contract signed with the hospital the other day for cardiac and pulmonary rehab. So if there are patients who are already existing in cardiac or pulmonary rehab and they would like to transition to hospice, they can still maintain that service. So they can still, if they're independent enough and want to, they can still come to the hospital and participate in cardiac and pulmonary rehab. If we do end up with a patient who has never done cardiac and pulmonary rehab and they're interested in that, then we could explore that option as well. So we do have two new brochures that will be coming out that are called Breathe and Heartbeat, and it's under a rhythms program. So it's nice to explain our services in a way that's not labeling it as hospice, because a lot of people don't like that direct approach, and they think hospice is scary. They think hospice means I'm dying tomorrow. So by relabeling it as rhythms program, it kind of helps to have that conversation in a more gentle way to hopefully reach a greater audience, if that makes sense.
Is that program for just people with heart and lung terminal illnesses, or like anyone that's going to cardiac rehab?
It would have to be heart.
Okay.
So COPD, and just heart failure,
Okay.
a cardiac event. So they'd still have to qualify for those qualifying diagnoses.
I was just thinking about the patients at the end of life, exercise and socialization and stuff helping. So
There's still the guidelines of the program, but just letting them know that they could still participate in those and go into the hospice program.
Any other questions?
I have one, but I don't know if it's too broad of a question or not. So many people think of hospice as where people go to die. How do you think that we could change people's perception of it? Like, because even people don't want to talk about it with each other, let alone when it's, their loved one or, someone who's their patient or things like that. How do you think that we can help them to understand that it's not just, okay, you're going to hospice and you're going to die on Thursday?
I think it's all about education and letting them know what types of services exist and some of these misconceptions that they may have, and clarifying those with them. That way they understand really what it's all about. And I think, providing them some printed education even on what hospice philosophy really is, because it truly is about maximizing the life that you have left. Mm-hmm. It's not about the death component. I mean, that's part of it, but the bulk of what hospice does is it supports life. So I think education is probably the biggest way to combat that.
And I would just say, I guess, when you started your whole presentation, it hurts a little bit to say, well, this is 180 degrees from what I did before. I think for all of us, if we all start to think about educating patients and asking them kind of what their plan is, like we talked about, like early on, and asking patients kind of how they feel about things, making sure that they have a good understanding. We can all start earlier and let people know they have options and say, okay, if you're at this point, this is kind of a program for you. And then we can start to, so I think it has to not only start with the hospice and how to introduce hospice. I mean, I think we all have to look at things differently, to start presenting things differently and listening to patients differently and making sure that we're giving them information and listening to their information so that we can all start everything sooner, not just at the end.
Absolutely.
I would say.
Yeah, absolutely.
Thank you.
Nicole, I have a question about what kind of education you provide to caregivers, because they're such an important role in patients' care. And the kinds of decisions that they may have to make, let's say if the patient themselves could not make a decision. So what kinds of services do you provide to caregivers?
So we do have a patient and family manual, and so it's a nice big binder that has lots of different resources in it. So some of them are pre-printed publications coming from other organizations, as well as things we have created. So it kind of does talk to the families about, it's a printed reference so they can go back to and look at, what types of things should I do if my loved one is having pain? How can I properly position my patient or my loved one to be more comfortable? What types of things to expect as a patient declines and nears the time of death. So we do have some materials in a big handbook binder that we give out, and then the nurses provide that education as they do their admission process. Every time they go and see the patient, they'll ask the caregiver, how are things going? What types of needs are you experiencing? That type of thing. If we are concerned about our caregivers at all, we can bring our chaplain in, and she's a non-denominational chaplain, and she loves to have just lots of different conversations with patients and loved ones, and so she can kind of help identify some areas of need that we can address. We also have our bereavement coordinator, so she can go in as well and kind of help identify what types of issues there are and provide education on those.
Great. Thank you.
Anything else?
Thank you. It was great. Thank you, Nicole.
And then I do have evaluation forms if you don't mind filling them out. They're very brief, just so that I can use this to submit with my project